Hi, y'all. My name is Jeremy Jacobs. I'm a rising junior at Duke University, and I've been interning this summer with the Payment and Delivery Reform team under Robert Saunders. Today, I'm going to talk about one of the projects I've been working on, which explores the way health system payers have enacted policy changes related to maternity care during the COVID-19 pandemic, and which of these changes might stick around after the end of the public health emergency. Before I move on, I want to thank Rebecca Whitaker and Yolande Pokum Chuisu, the Margolis staff that are spearheading this effort. So, to give a little bit of background, in many areas of the healthcare industry, COVID 19 has led to widespread changes in utilization. And in response, payers have adjusted reimbursement of healthcare services. This particular project emerged out of conversations with the North Carolina State Medicaid Agency and their interest in what other states are doing related to maternity care during the pandemic. And so we've examined Medicaid and commercial payer policies, and particularly those that aim to manage risk for pregnant women, integrate social determinants of health, prevent growth of health disparities, and mitigate provider financial distress. We began this project by doing an environmental scan to determine what payer policies had been published online. We examined 9 states, including North Carolina, New York, Texas, Ohio, and more, digging through the press releases and web pages of state Medicaid and managed care organizations. In the second stage of the project, we developed a detailed interview guide and began reaching out to a variety of stakeholders relevant to maternity care. Currently, we are conducting a range of interviews with representatives from providers, NGOs, professional maternity care organizations, Medicaid payers, and more. As we begin to wrap up our interviews, we are quickly moving into the final stage of the project, where we hope to develop and publish an issue brief in the coming weeks. While a lot of the analysis has yet to be completed, there are some clear themes that have emerged from the environmental scan and interviews. By and far away, the biggest change in maternity care has been the shift to telehealth and virtual care. In the last few months, utilization of virtual care has exploded, and in response, payers have increased reimbursement of telehealth and audio-only care to parity or near parity with in-person visits in many cases. I'll caveat this finding by saying that this change isn't specific to maternity care. It's part of the broader shift of many healthcare services to virtual care during the pandemic. But there are some unique findings. North Carolina Medicaid, for example, is now providing reimbursement for blood pressure cuffs, which allows pregnant women to monitor their health at home and avoid some in-person visits. And at least anecdotally, many payers and providers are finding high patient satisfaction rates with their maternity care patients. While less widespread, there have also been other changes affecting maternity care. In some areas like DC and New York, there have been changes to scope and practice, allowing some nurses and nurse midwives to take on greater roles, as well as a relaxation of certain licensure requirements. In several states, there have also been cost waivers that waive many of the copays for telehealth visits, including those for maternity care visits in many cases. And in New York, there have also been temporary expansions to eligibility that grant some uninsured and low-income women Medicaid coverage. These interviews have raised a lot of questions. Take, for example, the changes with telehealth. On the one hand, it seems to be a positive tool for expanding access, and prior studies of virtual care suggest that telehealth offers similar outcomes with lower costs to in-person visits. For this reason, maintenance of our current telehealth policies after the pandemic may help in the transition from our current volume-based and often wasteful healthcare system to one based more strongly in value. But some providers and payers have raised the question of whether telehealth may increase disparities by denying access to those lacking broadband or smartphones. So, as we analyze these interviews further, we are thinking through these questions and the future implications of these policies affecting maternity care. As for next steps, by the end of July, we plan to finish our remaining interviews and spend more time drawing out the common themes that have come up again and again in these interviews. And we've already begun a rough outline of what the issue brief will look like, and we aim to have an initial draft ready by the second week of August. And so that is the basic overview of where my project is at right now, and I hope that there will be more to share in the next few weeks. Thank you so much.